So today we'll be dealing with the visual pathway. The visual pathway starts from retina. Light rays will fall on retina. Then the fibers from retina comes out as optic nerve. So at optic chiasma, nasal fibers will cross. After crossing, they continue as optic tract, which relay in lateral geniculate body. So from lateral geniculate body starts the optic radiation, otherwise called geniculocalcarine tract, which reaches the visual cortex. So for any sensory pathway, there will be three order of neurons. The first order neuron in visual pathway is the bipolar neurons of the retina. You can see here. So these are the bipolar neurons of the retina, which are the first order neurons of the visual pathway. They are receiving impulse from rods and cones. So rod cells and cone cells. Then these first order neurons will give information to the second order neurons. These are the ganglion cells of the retina. The axons of these ganglion cells forms the optic nerve fibers. So these are the second order neurons. So the optic nerve is actually the second order neuron. Ganglionic cells of the retina are second order neurons of the visual pathway. They receive impulses from bipolar neurons. Axons of ganglion cells form the optic nerve. So third order neurons located in lateral geniculate body. Their axons form the optic radiation, otherwise called geniculocalcarine tract. So if you see the optic nerve, functional component is the special somatic afferent fibers. So optic nerve carries sense of sight from eye. So extinction of diencephalon. So it is an extinction of diencephalon during embryonic life. So develops from optic vesicle of forebrain. So that's why optic nerve, they regard it as tract rather than nerve, because it is covered by meninges also, and it is myelinated by oligodendrocytes, and there is no neurolemma, so regeneration is not possible. And then most important thing is this optic nerve develops from the forebrain optic vesicle. So once we know this, that the optic nerve develops from the optic vesicle, we can directly understand the remaining points, that it will be myelinated by oligodendrocytes, there will be no neurolemma, and it's also covered by meninges, and there is no regeneration because of absence of neurolemma. So optic nerve is the second cranial nerve, purely sensory, emerges from eyeball, about 3 to 4 millimeter nasal to the posterior pole, runs backward and medially to enter optic canal. So finally enters middle cranial fossa and unite with opposite nerve to form optic chiasma. So almost 4 centimeters long. Intraorbital part is 25 millimeter. Intracanalular part is 5 millimeter. Intracranial part is 10 millimeter. Ganglion cells of retina give rise to fibers of optic nerve. These fibers converge towards optic disc at posterior pole of eyeball, slightly medial to posterior pole. So these fibers pierce retina, choroid and sclera and emerge from eyeball as optic nerve. You can see here, this is the eyeball. So this area will be the optic disc where optic nerve is emerging. You can see here, this is the optic nerve and this is the optic chiasma. You can also see the crossing of the nasal fibers of retina, but temporal fibers will not cross. So this is the optic tract. So optic tract relays in lateral geniculate body. Then you can see the optic radiation, which is forming the geniculocalcarine tract, and you can also see few fibers from the lateral half of the lateral geniculate body. They are looping forward and they loop around the inferior horn of the lateral ventricle, so forming the Mayer's loop, and again they will relay into the visual cortex. So pass posteromedial in orbit and enters middle cranial fossa through optic canal. Both optic nerves join to form optic chiasma in middle cranial fossa. Located. So this optic chiasma is located at base of the brain in middle cranial fossa. Nasal fibers of optic nerve cross midline in optic chiasma to enter the opposite optic tract. Temporal fibers do not cross. So optic tract runs backwards and binds around cerebral peduncle of midbrain to reach lateral geniculate body. So some fibers of optic tract terminates in superior colliculus and pretectal nucleus. Lateral geniculate body, it is located below posterior part of thalamus, small and ovoid, receives fibers from optic tract. Neurons of lateral geniculate body are arranged in 6 layers, so which forms third order neurons of visual pathway. Layer 2, 3, 5 receive ipsilateral fibers, and layers 1, 4 and 6 receive contralateral fibers. You can see here 6 layers, 2, 3, 5 receiving same side fibers, and 1, 4, 6 receiving the opposite side fibers. You can see this is the field of vision. So this is the peripheral part and this is the central part. So peripheral part is represented in the ventral two-thirds and central part is represented in the dorsal one-third. And you can also see the upper part is represented in the medial half and the lower part is represented in the lateral half. So and again here if you come, this is the visual cortex. So the peripheral part of the retina is represented in the anterior one third, and the macular part, the central part, is represented in the posterior one third. So this will be the anterior two thirds. So peripheral part of the retina is represented in anterior two thirds, and central part is represented in the posterior one third. So this is the area which is spared during lesions of visual cortex, because this posterior one third will have dual blood supply both from posterior cerebral artery and middle cerebral artery. So that's why if there is damage to visual cortex, majority of the times it goes in favor of macular sparing because of dual arterial supply to the posterior one third, where there is large representation of the macula. So optic radiation, otherwise called geniculocalcarine tract. So axons of neurons of lateral geniculate body pass through retrolentiform part of internal capsule as optic radiation. These fibers end in visual cortex. So a part of the optic radiation forms Meyer's loop, otherwise called temporal loop, which arises from lateral part of lateral geniculate body, loops forward over the inferior horn of the lateral ventricle. Visual cortex, primary visual cortex, area number 17, located in walls and floor of the posterior part of the calcarine sulcus, also called as striate cortex due to presence of striae of Jenner. So isolated visual impressions like color, size, form, motion, illumination, and transparency are perceived here. But combining all these and identifying what we see is done by the secondary visual cortex, so which surrounds the primary visual cortex, area 18 and 19, recognition of objects seen. The lesion of the secondary visual cortex will cause visual agnosia, unable to recognize objects. You can see this is the posterior part of the calcaneus sulcus on the medial surface of the cerebrum. So this is the area number 17, primary visual cortex, and 18 and 19, the visual association cortex. We can see this is the binocular field of vision. So visual field of right and left eye both overlap in the center. So lesions of visual pathway, general terms like blindness, complete loss of vision, anopia, ipsilateral total blindness, means one eye blindness. Hemianopia, partial blindness, has loss of sight in half of visual field. It might be bitemporal hemianopia, which is a heteronymous hemianopia. Then homonymous hemianopia is loss of vision in same half of each visual field, whereas bitemporal is loss of vision in outer half of each visual field. So right homonymous hemianopia is loss of vision in right half of each visual field. Left homonymous is loss of vision in left half of each visual field. Superior is loss of vision in upper half of visual field. Inferior is loss of vision in lower half of visual field. Now coming to the actual discussion here. So in this diagram we can clearly see the site of lesion and what is the result here. So if you see, the number 1 indicates the complete transection of the optic nerve, which results in complete blindness of the right eye. So here you can see the sagittal cut in the optic chiasma, so where the nasal fibers are cut, which is resulting in the bitemporal hemianopia. So that means there will be a central tubular vision. And here you can see only the lateral part of the optic chiasma is damaged. That means the only temporal fibers are gone. So you can see this as a unilateral nasal hemianopia. And then if you see, there is damage to the optic tract and there is damage to the optic radiation, both represents or both will result in left homonymous hemianopia. Whereas once you go to the lesion of visual cortex, as I said earlier, there will be macular sparing. See, it is left homonymous hemianopia with macular sparing. And seventh is lesion in the upper lip of the calcarine sulcus, where you can see there is contralateral inferior quadrant anopia, whereas 8 is the lesion in the lower lip of the calcarine sulcus, which results in contralateral superior quadrant anopia. So these are the description of the earlier lesions. So you can see now this is the pupillary light reflex. So now the light is falling on the left eye. The left pupil also contracts as well as the right pupil also contracts. So when this light falls on the left eye, the left pupil contracts. So the source of light is on the left side and left pupil is contracting. So this is called as direct light reflex. When the source of light is falling on the left eye, and if right pupil is contracting, so then we call it as indirect light reflex or consensual light reflex. Let us see the pathway. You can see the light falling on the retina. So then it is traveling through the optic nerve and it is traveling through the optic tract. So this will be the optic chiasma. This is the optic tract. Then it is reaching the superior colliculus, where we can also see this is the pretectal nucleus. So you can see the pretectal nucleus is relaying bilaterally into Edinger-Westphal nucleus of both sides. So Edinger-Westphal nucleus, then the fibers will pass through the oculomotor nerve, ciliary ganglion, short ciliary nerves, and the sphincter pupillae or constrictor pupillae, which will constrict the pupil. So same way here also, from Edinger-Westphal nucleus, oculomotor nerve, and then the ciliary ganglion, the short ciliary nerves, and to the constrictor pupillae and constriction of pupil. So this will be the direct light reflex, and this will be the indirect light reflex. So this is the pathway: light rays on eye, optic nerve, optic chiasma, optic tract, pretectal nucleus, Edinger-Westphal nucleus, ciliary ganglion, short ciliary nerve, and contraction of the constrictor pupil and constriction of the pupil. So then accommodation reflex. So it follows the visual pathway: the light, optic nerve, optic chiasma, optic tract, lateral geniculate body, optic radiation, visual cortex. From visual cortex, the information is given to the frontal eye field through superior longitudinal bundle, and then from frontal eye field, corticonuclear fibers going to the motor nucleus of the third cranial nerve, and again Edinger-Westphal nucleus of the third cranial nerve, then passes through oculomotor nerve. So here it goes to medial rectus muscle and ocular convergence. So here it goes to constrictor pupil and ciliary muscle, and there will be constriction of pupil and thickening of lens. So three things are happening here: ocular convergence, both eyes coming medially, then constriction of pupil and thickening of lens. All these three will facilitate the accommodation reflex. Thank you.